So I'd like to introduce Dr. David Tripp. This is Dr. David Tripp, Clinical Leader, General Medicine, Wellington Hospital, Intensivist at Large. I like that. You also cycle, don't you?
Yeah.
Yeah, so we're cyclists together in a world that hates cyclists, I think.
Oh, no.
Over to you, David.
Thank you. Heather, thank you for your love and courage. As well as being those things, I've just got to say I'm the RACP rep on the HQSCDP EAG, just so you know. I work with the elderly every day, and at present I am thinking of Elizabeth, Janet and Margaret, 3 elderly deteriorating patients who I looked after earlier this week, all with U's scores of 0, and I dedicate this talk to them. I'm going to try and be a little bit edgy without being career limiting. I have a conflict of interest. I'm an intensivist and a general physician. I have a split personality and I change my colours depending on my surroundings. As an intensivist, this is how I view the wards. Places of chaos, death and trauma. Why would you send a patient there? And you know, they're always complaining of being bed blocked. Don't they know that we are cancelling cardiac surgery today? As a general physician, I have a view of ICU. Conveniently constructed without doors. Today, perhaps at my peril, I'm going to adopt this perspective, conscious perhaps that I'm the only general physician in the room. And then we throw elderly, vulnerable people into the mix, and the story becomes quite murky. I'd like to start with a few numbers, mainly because that gives the rest of my talk an air of evidence, which between you and me is something that is completely lacking. Whatever the issue is with the elderly, would you please fasten your seatbelts? Over the next 15 to 20 years, we're going to see roughly doubling a number of the people over 65 and over 80. So for those of you who are under the age of 50, there are 1 or 2, this is happening during your career. But firstly though, can we stop seeing this as a problem? A challenge, yes, but not a problem. Each of these people is a wonderful person with value, with history, with wisdom, with a family who they will care about, with real fears and with real things to offer. And these people will also come with significant health issues, and it will be our privilege to care for them. And I want to do that well. And yes, there will be a jolly lot of them. Where do they hide in our hospitals at the moment? This is the percentage of patients over 80 by service. Gen Med is way out there in front. You won't find many in maternity. I think there's a coding problem there. But you notice this whole cluster of surgical services, and who would have thought of ophthalmology as the second highest hotbed of geriatrics in your hospital? I've got to say that when I look at that cluster of surgical services, I get a little bit nervous. And if death is the final common pathway of the deteriorating patient, where does that happen? So the deteriorating patient is core business for us in general medicine. Oh, with all this, we have a growing number of elderly people. Many of them will be in Gen Med. Many of them will deteriorate. And so just a plea from my corner of the ring that Gen Med must be firmly embedded in a good escalation and rapid response system. So, there ends the evidence. I'd like to talk to you about some of the tensions I feel in this space. First, a story. This is my dad. I'm very proud of him. This is him earlier this year walking the Milford track with his 2 artificial hips and a lumbar spine full of metal. He's 86. He's on fewer regular medications than I am. We should be very careful not to put the elderly in boxes. However, first comment as I look at these people and in the context of deteriorating patients is I want this to be about what for, not for. This is a graph of the inpatient and 2-year mortality of ventilated patients over the age of 80 in New Zealand ICUs. Look at the column on the right. The minority of these highly selected patients that survive ICU, a minority survive ICU, the majority go on to die in the near future. So that says to me ICU is not much help. And we make that the not for. But what should we then do for the deteriorating elderly patient? This is just an example prompted by the 3 patients I looked after earlier this week. If you have a cardiovascular collapse and need cardiovascular resuscitation, we've got an amazing system for you. You'll have your fluids, you'll have your inotropes, you might get your intra-aortic balloon pump, and if you're really lucky, you get popped on a plane and flown to Auckland for ECMO. If you have acute brain failure, we call it delirium, for which I think we should be thinking of brain resuscitation. We pray and walk away. I struggle daily getting the resources I need to help my elderly patients with delirium. There's a lot we can do. It's just too hard. Can't source them for love nor money. In terms of the what for and not for, goals for care is something that we have been trying, and I've just been thrilled with how it's gone. We've ditched our not for resussy sort of forms, and along with the whole package of teaching and culture, we now have this form in Wellington. Since July, we've had 80 people die in our service. Every one of them has had a goals of care form in place at the point they died. 2 wanted CPR and got it. 78 said no thanks and didn't. The next tension I face is the idea of preventing versus rescuing deterioration. Because once an elderly person is in free fall, there's often not a lot that can be done. We are in a system with no more money. We have to make hard decisions. So I'm very concerned about the fence at the top of the cliff, as concerned with that as the rapid response team, as the ambulance at the bottom. Imagine this iceberg is everything we do to prevent deterioration. I would see our rapid response systems, our MET teams, our power services as the very visible tip at the top. It's good. What's beneath is what's happening every day on our wards. And particularly in terms of our escalation pathways, we have 10 calls to a ward RMO for every deteriorating patient for every 1 MET call. But that's a big black box. We don't count that. We don't know what's going on there. We don't know if they're being called appropriately. We're certainly not training them for that task. I'd love to do more in that space. The other thing, as Alex alluded to this morning, is our solar-powered hospitals. On weekdays, we have 27 doctors in our service. On weekends, we have 7 doctors in our service. Saturday is our busiest day of the week for admissions. So you get what you pay for. I believe firmly in the urgent review of a deteriorating patient. My sadness is that the only option I have to do this is to pull staff from a ward round where they were busy hearing a patient's story and building that trust. or to pull them from admitting a patient in ED and therefore leave an elderly patient on the trolley for even longer. The next tension I face in the deteriorating patient space is the tension between experts and learners. I think it's a very welcome move to get experts to the bedside early. I also have 45 junior doctors who need to learn. Now, if it was my mum, I know who I'd want at the bedside. I'd want the expert, thank you. But I also want well-trained people to be available to come to my bedside in 30 years' time. Somehow we need to get the expert to the bedside and need to reskill our juniors in a space that I think they have moved away from. We've been trying that in Wellington. I teach registrars a course through their run with a variety of, and I survey them before and after with a variety of scenarios, and they rate themselves from wetting themselves to a piece of cake. And yes, they're learning. That is good. This is something that can be done. My sadness is that attendance at the training is less than 50% because they just can't get there. So putting that all together, second to last slide, when you talk to me about the deteriorating elderly patient, I think of a whole lot of bits of the system that have got to fit together. We need training. A deteriorating patient's got to be something that's grounded in an adequately resourced and well-trained ward-level care. We need to be thinking about our goals of care. Please, can we also think about good delirium care and the benefits that can come from good care, the harm that comes from our current care, as well as a sound, well-resourced system for measuring and responding to deterioration. So, what's my brief wish list? I'm an enthusiastic advocate for the deteriorating patient program and think much of what we've heard of the last couple of days is a tribute to the work that has been done, with special acknowledgement to Alex, Gary, Emma and the HQSC team. Wearing the hat of someone who cares for the elderly, can I just add a few things to the list? Can we talk about what for, not for? What not for just leaves our elderly people abandoned, I think. Can we manage delirium a little better? Could we recognise and optimise the cost of pre-met call escalation so that our wards work better and we're using that substantial resource well? We've got some work, I think, to do over time in making our met calls themselves hum a little better, the right people to the bedside at the right time. And I'd love to be able to invest more in training our ward staff. So that's it from me. Thank you.